the various infections. First, we will discuss about amoebic liver abscess. Now, the causative organism of this amoebic liver abscess, it is Ant amoeba histolytica. So, what is the causative organism? It is Ant amoeba histolytica. Now, this amoebic liver abscess, it is also called as tropical abscess. It is also called as tropical abscess. Also called as tropical abscess. Why? Because it is more common in Indian subcontinent and Africa. Now, what is the most common extra-intestinal manifestation of amoebiasis? The answer is liver abscess. So, the most common extra extra-intestinal manifestation of amoebiasis, it is amoebic liver abscess. Clear? Now let us discuss the pathway of the spread of this infection. Now, after an attack of amoebiasis, the infection, it travels from cecum through superior mesenteric vein and portal vein. The infection travels from the cecum to superior mesenteric vein and portal vein. Now let us understand this with the help of a diagram. Now suppose this is liver and this is bowel. Now we have, this is superior mesenteric vein. It joins the splenic vein. This is splenic vein. This is superior mesenteric vein. After this, we have inferior mesenteric vein also, carrying the blood supply from the bowel. And this superior mesenteric vein, this splenic vein, it forms portal vein which divides into right and left branches. So if we see the direction of the blood flow, it is like this. Now what happens? This is the cecum. The infection travels from the cecum via the superior mesenteric vein, then reaches to the portal vein and then spreads to the either to the right and or left lobe of the liver. Now the most common site where this infection can lodge is right lobe of the liver. So which is the most common lobe involved? It is the right lobe. Now there are two reasons. One is the streamline effect. Streamline effect. Clear why? Because the right branch, it is in direct continuation with the portal vein. So this is called a streamline effect. Also, the right lobe is larger in size. So second important feature is larger in size. So due to these two factors, one is the streamline effect and another is the larger size of the right lobe of the liver. The most common lobe involved, it is right lobe of the liver. Clear? Okay, next if we see, so this was from the right lobe of the liver, from the right side, and from the left side of the bowel, it travels via inferior mesenteric vein. So we can say from the rectosigmoid, this is rectosigmoid. What is the route of spread from rectosigmoid? It is from inferior mesenteric vein, then splenic vein, then portal vein, and after that to the right and left branches of the portal vein into the liver. So this was the mode of spread of liver abscess to the liver. Now if we see in the liver what happens, once the infection has reached the liver, in the liver, what happens? The trophozoites, they destroy the hepatocytes. They destroy the hepatocytes. How? By releasing an enzyme which is called as histiolysin. They release an enzyme which is called as histiolysin, and this histiolysin, it is a cytotoxic agent and it destroys the liver hepatocytes. So it is a cytotoxic agent. And once there is destruction of the liver hepatocytes, what happens? It can lead to liquefactive necrosis. Liquefactive necrosis, there can be thrombosis of blood vessels. After that, there can be breakdown of RBCs. And all these three, they can result in formation of a pus which is termed as anchovy sauce pus. Which is termed as anchovy sauce pus, which is typical of amoebic liver abscess. So it is typical of amoebic liver abscess. This is very important. Now, why it is called as anchovy sauce pus? Because it is chocolate. It is a chocolate brown colored and it is odorless. Now, anchovy sauce, it is basically a sauce which is produced from a fish. So that is why this is also termed as anchovy sauce pus. Now, there is one important point. Please note that trophozoites, they are found in the wall of abscess cavity. They are found in the wall of abscess cavity and not in the content. So this is very, very important that the trophozoites of these Entamoeba histolytica, they are found with lining the wall of the abscess cavity and they are not found in the content of the abscess cavity. So next, if we see in 80% of the cases, there is a single large abscess. Single large abscess in 80% of the cases, whereas in 20% cases, they are multiple. Clear? Now let us discuss about the life cycle of Entamoeba histolytica. This is basically a microbiology question, but sometimes it is asked in the exam. So let us discuss the life cycle of Entamoeba histolytica. Now what happens? The mature cyst in the feces, they contaminate the food. They can contaminate either food or water. After that, what happens? If we ingest this food, we basically are also ingesting the cyst. Clear? After that, what happens? These cysts, they pass through the stomach undamaged because the acidic medium in the stomach, they cannot destroy them, whereas the alkaline medium, what happens in the alkaline medium? Excitation occurs. Excitation occurs with the help of enzyme called trypsin. So excitation, which is basically what? It is basically lysis of the cyst wall. It occurs with the help of an enzyme which is called as trypsin. After that, what happens? There is release of, after excitation, what happens? There is release of quadrinucleate amoeba. And after this, the metacyst trophozoites are formed. Metacyst trophozoites, they are formed, and the habitat of these metacystrophocytes, the habitat is in the crypts of cecum followed by rectosigmoid. So the habitat of these metacystic trophocytes, they are where it is in the cecum on the right side, or it can be on the left side in the rectosigmoid area, and they ultimately lead to formation of they reside there and lead to formation of trophozoites. And then these trophozoites, they ascend with the help of superior mesenteric or inferior mesenteric veins up to the liver. So next is, what are the clinical features that the patient will present with? Let us discuss the clinical features. Now the patient can present with two types of presentations. There can be acute presentation or chronic presentation. Now let us discuss the clinical features in each type of presentation one by one. So first we will discuss about acute presentation. Acute presentation. Now in acute presentation, what will the patient present with? Patient will present with high grade fever with rigors and chills. So patient will have, there will be high grade fever with rigors and chills. After that, the patient may present with jaundice. And if we see on clinical examination, there will be tenderness in the right hypochondrium, and intercostal tenderness will also be present. So patient will have tenderness in right hypochondrium, and intercostal tenderness is also present. Now sometimes the patient can present with thoracic symptoms in the form of dry cough, chest pain, sometimes right shoulder pain, and in some cases a right side pleural effusion. And the pleural effusion due to a liver abscess, it is termed as sympathetic pleural effusion. So it is termed as sympathetic pleural effusion. Clear? Now if we see in chronic presentation, what the patient will present with? In chronic presentation, patient may present with firm to hard, smooth, non-tender, palpable liver. Clear? Now the most common symptom of amoebic liver abscess, it is abdominal pain. So the patient will present with pain in the right hypochondrium. The most common symptom of amoebic liver abscess, it is abdominal pain. Clear? Now next let us discuss the various sequelae of amoebic liver abscess. So sequelae of amoebic liver abscess. Now first is rupture into the lungs. Rupture into lungs. Now rupture into the lungs, it is the most common site of rupture. So it is the most common site of rupture, and it is also called as pleuropulmonary rupture. Now the patient will have what? Patient will have expectoration of chocolate colored sputum. Clear? Now next there can be rupture into the bronchus. There can occur rupture into the bronchus, and this can lead to bronchopleural fistula. Bronchopleural fistula leading to coughing of Owais Zargar. After that, number third, there can occur rupture into the peritoneal cavity. Rupture into peritoneal cavity, which can result in peritonitis. And this is an emergency condition, and we have to go for surgical intervention, that is exploratory laparotomy. So you have to do emergency laparotomy in such cases. After that, let us discuss the diagnosis part. Now in the diagnosis, first we will go for blood investigations, and in the blood investigations what we will find, there will be increased in leukocyte count, so increased TLC, and if we do the LFTs will be deranged. So the liver function tests of the patient will be deranged and there will be increased total leukocyte count. Now the most common LFT abnormality. What is the most common LFT abnormality? This is very important question. It is prothrombin time. Prothrombin time, it is widened. So widening of prothrombin time, it is the most common LFT abnormality. Now how we are going to correct this? We are going to give injection vitamin K 10 milligrams IM is given for 5 days. So injection vitamin K 10 milligrams intramuscular is given for 5 days, and FFP transfusion can also be given. Now next important modality is we go for ultrasound abdomen, and what it will show, it will show an anechoic or hypoechoic lesion in the liver. Now ultrasound, with the help of ultrasound we can determine the size, the location and the number of the abscesses in the liver. So with the help of ultrasound we can determine the size, location and number of abscess. Clear? Now if we do a chest x-ray in such cases, what will happen? There will be tenting of the right side of the diaphragm. So there will be elevation or tenting of the right hemidiaphragm. So what will be the chest x-ray findings? There will be tenting, tenting of diaphragm, that is raised right hemidiaphragm, and there can be sympathetic pleural effusion. Sympathetic pleural effusion. Clear? Now next modality is CT scan. Now CT scan, it will show the abscess cavity. It can show the size, the location, the number, and we can also see the pleural effusion. Now there is an important test, technetium 99 scan. It is used to differentiate amoebic liver abscess from pyogenic liver abscess. So there is an important test to differentiate amoebic liver abscess from pyogenic liver abscess, that is technetium 99 nuclear imaging. It is used to differentiate amoebic liver abscess from pyogenic liver abscess. Now on amoebic liver abscess, what it shows a cold lesion with hot rim or halo. Why in amoebic liver abscesses we will find a cold lesion with a hot rim? Because I told you that in the abscess cavity the trophozoites they are absent. So this pus it is basically sterile. So it will show a cold lesion, and these trophozoites they are present surrounding the abscess cavity in the wall of the abscess cavity. So what we will find on technetium 99 scan, it will show a cold lesion with a hot rim or a hot hollow outside. Whereas in pyogenic liver abscess, it is entirely hot. Clear? Okay, next, what is the investigation of choice for confirmation of diagnosis? The investigation of choice for confirmation of diagnosis is serological tests, that is ELISA for anti-amoebic antibodies. So the investigation of choice for confirmation of diagnosis, these are the serological tests, that is the ELISA test for anti-amoebic antibodies. Now next, let us discuss the treatment part. Now in the treatment, first we will discuss medical treatment. Now metronidazole, it is the drug which is given in the medical therapy, and it is given in the dosage of 750 milligrams TDS over a period of 2 weeks. So the drug is, we have metronidazole, oral metronidazole. It is given in the dose of 750 milligrams orally 3 times a day over a period of 2 weeks. And if you have to give injectable metronidazole, it is given in the dosage of 500 milligram intravenously 3 times a day over a period of 2 weeks, and this is the mainstay of treatment, and it has been found to be curative in 90% patients. So it is found to be curative in 90% of the patients, and the patients become symptomatically better within 3 days of giving this drug. So the patients become symptomatically better, or clinical improvement is seen within 3 days. Now, alternatively, tinidazole 600 milligrams BD can be given over a period of 5 days. So, alternate drug is tinidazole. Tinidazole, it can be given in the dosage of 600 milligrams twice a day for a period of 5 days. Clear? Now, next, if there is a small abscess, what are small abscesses that is less than 3 centimeters? They show good response to drug. They show good response to drug. Now we have certain luminal agents. What are these luminal agents? Have a look. We have luminal agents also. And these luminal agents, they include paromomycin, then iodoquinol, and diloxanide purate. You can remember it with the help of mnemonic PID. Average time for radiological resolution of the abscess cavity, it is 3 to 9 months. So the average time for radiological resolution of abscess cavity, it is 3 to 9 months. Now next, let us discuss the surgical treatment. Now we have open surgical drainage of the abscess. Now first we will discuss the various indications of the surgical management. So what are the indications? Number one is even after repeated aspirations or percutaneous drainage, after repeated aspirations or percutaneous pigtail drainage, even after this, if abscess cavity fills again. So what happens in these abscesses? We can insert a pigtail or we can do a percutaneous drainage. But even after repeated percutaneous drainages or pigtail drainages, if there is again filling up of this cavity, then it means we have to go for open surgical procedures. So this is the first indication of open surgical procedure. So this is basically indications of open surgical drainage. Open surgical drainage. Now, what is the second indication? If there is multiloculated abscess, because you see these multiloculated abscess, they will contain thick pus, so it will be very difficult to aspirate them or to do them to evacuate them with the help of a pigtail drainage. So we will go for an open surgical drainage. After this, if there is a left lobe abscess. Because there is drainage of rupture into pericardial cavity. So because there is risk of rupture into pericardial cavity. Now, number fourth indication is in case of ruptured abscess. If there is ruptured abscess, then we have to go for open surgical drainage. After this, in caudate lobe abscess, then after that, if there are multiple abscesses in the liver, we have to go for open surgical drainage. So multiple abscess. Now how we do this open surgical drainage? Through a transperitoneal approach, we reach up to the abscess cavity. The abscess cavity is opened, the pus is drained and evacuated. After this, what we do, we place a drain in the abscess cavity and then the abdomen is closed. Next, we will discuss about pyogenic liver abscess.